Good afternoon, everyone. Thank you for joining today's webinar to discuss the important research that we have uh, about the attachment and biobehavioral catch-up. We know this research has been developed and is regarding early childhood development. And so today we will talk a bit about social emotional development in young children and how it is a critical factor related to later in life outcomes, such as school success, social interactions, and mental health. A growing body of research demonstrates that investing in science-based short-term early interventions pays off over both the short and long term, delivering lasting results that not only change lives for the better, but also produce substantial return on investments. The Attachment and Biobehavioral Catch-up Program, or ABC, is an evidence-based home visiting intervention for caregivers of infants and toddlers who have experienced early adversity. It is designed to buffer the harmful effects of toxic stress and to help support normal early childhood development. To explore the effectiveness of ABC with Kansas families, the KU School of Social Welfare, supported by multiple Kansas philanthropies, including the Health Fund, worked with several early childhood and mental health organizations across the state to research this program. Now, 7 years later, the Kansas ABC Early Childhood Initiative has concluded, and we're excited to share and discuss the results of the second phase of the work. Today's webinar will include a presentation from Dr. Whitney Gruby, Assistant Professor at the University of Kansas School of Social Welfare, and Dr. Amy Mendenhall, Vice Provost for Faculty Affairs and Professor at KU School of Social Welfare. Following their presentation, we will have a panel of reactors who will provide insights into this topic from a variety of perspectives. Our panel discussion will include Elizabeth Wright-Brock, Senior Fellow at the Georgetown University McCourt School of Public Policy Center for Children and Families, then Travis Rickford, Executive Director at LiveWell Northwest Kansas, Audra Kinnison, Mental Health Coordinator, Foster Care Coordinator, and HIPAA Compliance Officer at the Rainbows United Kids Point. And then finally, we'll have Melissa Warfield, the Director of Medicaid Policy and Research at the Kansas Department of Health and Environment. Before turning things over to Whitney and Amy, here are a few of our housekeeping items. Given the number of people that we have on the call, your lines are muted. However, we hope that you will use the chat function to engage throughout the webinar. We will hold full question and answer until after the completion of the initial part of the webinar from Amy and Whitney, and then we will move into the panel reactions there. However, if there are technical questions in the chat, Whitney and Amy may be able to address those quickly before the panel, so you can use that as well. To get things started, please introduce yourself in the chat. And again, please ask any questions within the chat, and we will be monitoring it throughout the webinar, and we'll take questions after the presentation. We will also plan to use the raise hand function to call on folks later in the webinar. However, we encourage you to ask questions in the chat throughout. With that, I'll turn things over to Whitney and Amy to get started.
Thank you so much, Katie. Good afternoon, everyone. Whitney and I are thrilled to be here. This is just such an exciting time, and we're excited to share the findings from kind of this long period of work that we have done in partnership with so many of you. So thank you again for being here today as we delve into the phase 2 evaluation of the ABC program here in Kansas. So building on the foundation of phase 1, which provided valuable insight into the program's initial implementation and outcomes, phase 2 focuses on deepening our understanding of ABC's impact and exploring new dimensions of its effectiveness. So your engagement and expertise are invaluable as we work together to translate this knowledge into action, ensuring that ABC continues to make a meaningful difference for Kansas families. I'm looking forward to sharing this next chapter of our work with you all today and to the thoughtful discussion that will follow. So for those of you that don't know, the work we're presenting on today is an expansion of the work previously done in what we dubbed phase one. So I just wanted to give a quick overview of what phase one demonstrated. So in terms of caregiver concerns, we found that regarding child social emotional functioning, it decreased. We had children's cortisol level that we measured as an indicator of stress, and we found that became more normalized. Parent coaches rated children's overall well-being as more positive, and caregivers' knowledge and beliefs in their caregiving abilities increased, and interactions with their children, caregiver intrusiveness went down, while sensitivity and delight went up. And then we found overall caregiver capabilities significantly improved, and there was just overall expanded capacity for early childhood services across the state. So you can see to the left-hand side, the diagram that shows we had these outcomes that impacted all different levels: child, parent, caregiver, household, and service systems and settings. So why phase two? Well, we had such positive results from phase one that we wanted to continue the work, but with some additional considerations. So phase two involved a transition to new areas of inquiry. Phase one of the Kansas Early Childhood Initiative demonstrated positive outcomes locally, including those improved caregiver activity, caregiver knowledge, and caregiver beliefs about parenting. And given those established findings, phase two shifted focus to measure other outcome areas that had not yet been studied or verified in Kansas. Additionally, in phase one, we had a lot of different measures and things that we were doing that did take a lot of time. And so we looked at a reduction of evaluation time and effort for phase two. A phase two evaluation plan aimed to decrease the evaluation burden for both parent coaches and caregivers, and this was achieved by reducing the number of evaluation components at the different time points. We also had an addition of child development measures central to school readiness. So to align with phase two's provision of the ABC early childhood model in Kansas, the evaluation included new measures aimed at assessing development and preschool readiness, specifically the Ages and Stages Questionnaire 3 and the Behavior Rating and Inventory of Executive Functioning Preschool version, also known as the Brief P. Additionally, phase two continued to evaluate ABC infant and ABC early childhood's impact on toddler and infant social emotional development as measured by the Ages and Stages Questionnaire Social Emotional 2. And then also phase one's implementation process and evaluation suggested that caregiving, despite its stresses, had inherent rewards. And so it was suggested that ABC often led to caregivers feeling more empowered post-ABC completion and feeling actually less stressed. And so in phase two, we decided to more systematically examine those outcome measures or outcome areas. And so we added measures related to those areas. So we introduced in phase two, we also introduced an additional ABC curriculum in the ABC early childhood curriculum, and we continue to use ABC infant as well. You can see here in this slide a comparison of the two. Both models are 10 sessions, with ABC infant focusing on infants 6 to 24 and really focusing in on increasing parents' nurturing care with children when children are distressed, helping parents follow children's lead, decreasing frightening parenting behaviors. ABC Early Childhood is aimed for 24 to 48 months, focusing in on increasing parents' nurturing behaviors when children are distressed as well. Similarly, helping parents follow children's lead, but then also encouraging parents to serve as co-regulators for their children under challenging conditions. ABC Infant continued to be implemented in 3 sites: Livewell Northwest Kansas, Rainbows United, and Russell Child Development Center. And then 2 sites, Livewell Northwest Kansas and Russell Child Development Center, expanded to implement ABC Toddler. Here you can see a breakdown of the phase 2 measures that were used for both models, infant and early childhood. We had demographic forms, the household strength and strain inventory, which measures toxic stress and protective factors, a home visiting form, which collected information about other services that were being delivered. As I said, the ages and stages questionnaire 3, the ASQSE2, the parental stress scale, and the family empowerment scale. The main difference between the two was the addition of the brief P for that preschool age. So for the, as I said, for the ASQ3 and the ASQSC2, both were measures that were utilized. For the ASQ3 scoring, we looked at total raw scores that were compared to the standardized cutoff points provided in the manual and the scoring guides to determine developmental status. Higher scores suggested typical development for the corresponding domain, while lower scores can indicate the need for further assessment of monitoring. And for those of you familiar with ASQ3, you know there's those 21 different versions that relate to the age of the child. And then with the ASQ SE2, one raw cumulative score is provided per a questionnaire, and this total score is then compared again with standardized cutoff points, which are provided in the manual and scoring guides, and that indicates whether the referral to intervention or additional assessments are needed, and if the child should be monitored or if there are no concerns requiring further action by the clinician. And so using those total score and the predetermined cutoffs, a ratio score is calculated. And anything above a 1 would indicate further referral and intervention. Anything below would indicate no further action is needed. And again, with this measure, there are 9 different versions related to the age of the child. And again, this focuses in on those social and emotional concerns, whereas the ASQ3 is focusing in on the development and developmental delays. So as I mentioned, we did add the parental stress scale, and this is a self-report scale to comprehensively assess both positive and negative aspects of childhood. It's derived from the parental stress index, and it looks at positive themes of parenting and caregiving, such as emotional benefits, self-enrichment, and personal development, while also addressing those negative themes which emerge, such as the demands on resources, self-enrichment, and demands on resources, opportunity costs, and restrictions. And this dual focus facilitates a more nuanced understanding of the caregiver's experiences. And then as I said, the other measure we added here was that family empowerment scale. This contains 34 questions, 3 different domains focusing on feelings about family, child services, and feelings towards community. This evaluation only examined 2 domains, the feelings about the family and also feelings about child services, which is just 24 questions. This is a measure that is measured on a Likert scale with responses from 1, never, to 5, very often. And then the total scores are calculated with a higher score indicating higher need or higher empowerment. So then the final is the brief P. So this again is the behavior rating inventory of executive functioning preschool. It's a standardized scale comprised of 63 items, has 5 different domains that you can combine into 3 different indices, and then an overall composite scale. And this is really focused in on measuring school readiness skills such as planning, organization, self-regulation, and adaptability. It's completed by the caregiver with higher scores indicating more problematic behaviors. And here you can see kind of how those different domains combine to form different indices here in terms of inhibition and emotional control, leading to an index for inhibitory self-control, and then having emotional control and shifting, combining for a flexibility index, and then working memory, planning and organization, combining for metacognition. And all of that combines for an overall global functioning measure. And with that, I'm going to turn it over to Whitney to share what we found.
Thanks, Amy. So I am going to talk to you about our results. And I first want to talk about really our enrollment information and what our sample size looked like. So for our infant sample, we had 92 families complete time 1 information, and then we had 74 families complete time 2 information. That results in about an 80% completion rate, which is actually substantially better than what we saw for phase 1. Phase 1, we had more families, but we had only about a 61% completion rate. So this is really a lot better than what we saw with phase 1. For our toddlers, we had 76 families submit time 1 information, and then 54 families submit time 2 information, which equates to about a 71% attrition rate, which is still a lot better than what we saw in phase 1. So getting into kind of the demographics, the average age of the infant sample was about 15.7 months, with a slight majority being male. About 56% were male. Additionally, 85% were identified as white and 46% were identified as non-Hispanic. So while ABC is intended to be administered to really any caregiver, we did see in our sample that 92% of those caregivers who received ABC were moms. 54% were non-Hispanic. 85% were white, and then the average age of our infant sample caregiver was 28.5 years. I also wanted to add, I don't have this on this slide, but I think it's important to note that we continue to have this overrepresentation of Hispanic families in our sample, which I think is fantastic. It adds to the literature of ABC. I also wanted to note that about 72% of our families reported making less than $30,000 a year, and most of them were, the family size was about 4. So indicating that a lot of these families were in poverty. So for analysis for the ASQ3, we didn't look at the domain scores. We contacted the developers to really see what would be the best approach to doing analysis for the ASQ3, and they recommended looking at how many infants met that threshold or met that cutoff to where they needed referrals versus how many did not meet the cutoff or whatnot. And what we found was that really physical development outcomes were not statistically significant post-ABC completion. But looking at the, let me go back a couple, looking at the ASQSE2 measure, we could do a little bit different of analysis with this because there's this total score that is given. And so doing analysis on the total score, we could look at the average item score for each of these kids. And we did find statistically significant decreases in, again, social and emotional concerns, reiterating kind of the findings that we found in phase 1. Also with the ASQSE2, we then did look at kind of the same thing that we did with the ASQ3 to see if there was any difference in kids that met the threshold and they needed more referrals versus not meeting that threshold. And we did see statistically significant reductions in this number as well. So kind of key takeaway from this is fewer infants needed additional assessments for social and emotional concerns, and overall scores did decrease. For the family empowerment scale, for time 1, the mean score was about 49.8 for the family domain again, and then for the child services domain, it was about 53.1. For time 2, the mean score for the family domain was 52.1, and the mean score for the child services domain was 55. And so what this is telling us across the board, looking at the individual domains and then that total score, results are indicating that infant caregivers' feelings of empowerment really improved from pre-ABC or at ABC initiation to post-ABC or ABC completion. For the parental stress scale, the baseline total score for parental stress was about 36.5. So on this scale, again, higher scores indicate higher stress levels. For time 2, it was 32.9. This also was statistically significant. So we found that caregivers for infants reported overall feeling less stress post-ABC completion. Moving into our toddler sample, getting into some of those descriptives, the average age of the toddlers was about 33 months, which is about 2 years and 9 months old. While the infant sample had that more majority or slight majority of male, this was evenly split in terms of male and female. 38% were non-Hispanic, 93% were white. Again, predominantly getting implemented with mothers, as about 89% of our caregivers for toddlers were mothers. 44% were non-Hispanic, 96% were white, and the age for our toddler population is a little bit higher at 31.4. I also want to note with this, while the infant caregiver sample had about 72% of families making less than $30,000 a year, the toddler caregiver sample had about 51% making less than $30,000 a year. The household size was roughly the same as about 4. So still there's some, you can extrapolate that there are, poverty is being experienced by these families. Looking at the ASQ3 for the toddlers, it's very similar to what we found with the infants. So looking at those differences in meeting cutoffs versus not meeting cutoffs, there really was no statistical change there. So physical development outcomes were not necessarily significantly different post-ABC completion. But I do want to note sample size is a limitation with this too. So it maybe isn't that it's not being impacted, but we did have some sample size limitations. We only had 54. And also because we have kind of the differences in intervals on which you complete and which you don't complete, it makes comparisons just a little bit more challenging for this kind of measure. For the ASQSE2, when we looked at those average item scores, just like the infants and just like we saw in phase 1, it's decreasing. So we know that toddlers taking or receiving ABC curriculum are seeing decreases in their social and emotional concerns. When we looked at those threshold numbers on, kids needing referrals versus not meeting referrals, it didn't show statistical significance for the toddler population. But again, I tend to think about our sample size and just limitations with the sample size as that is an issue. For our toddlers, the time 1 mean score for the family domain, when we look at the family empowerment scale, was 48.4, and the mean score for the child services domain was 51.7, or about 51.7. For time 2, we can see that the family total score was 51, and the child services total score was 55. Results really indicate that caregivers' feelings of empowerment really improved from pre to post. The parental stress scale saw a statistically significant change. So we saw that, again, caregivers of toddlers reported feeling less stress post ABC completion. The time 1 average score was about 35.9. Time 2, it was 33.1. So the brief P, Amy talked about this being a really long measure. It's 63 items, which is quite lengthy, and it has 3 different indices in it and an overall score. And when we looked at the analysis for this measure, we did see statistical significance in most things. There were a couple things that we didn't see much change in, particularly like looking just at the shifting domain and that emotional control. There wasn't statistically significant changes there, but there were in inhibition, in the working memory, and planning and organization. And then when we look at the 3 indices, we saw statistical change in inhibitory self-control, emergent metacognition. We didn't see statistical significance in the flexibility index. But then there's this overall score that you can look at, and overall, we did see a decrease in problem behaviors on the scale. So moving into just kind of implications of really what all this means, through the administration of all of these different measures, phase 2 really demonstrates that ABC infants and ABC early childhood leads to healthier kids. There's increased school readiness among our toddlers. We see that there's reduced caregiver stress, enhanced caregiver confidence, and advocating for their family. We know that all of these things lead to better family dynamics, which lead to overall better functioning for children. The success of this initiative really underscores the importance of continued investment in early childhood interventions that support both child development and family well-being. In conclusion of kind of both of what these phases have meant and what they mean going forward is we have, through this evaluation, through our efforts in phase 1 and phase 2, we have been able to demonstrate that ABC infant is effective within Kansas's unique demographic and service context. So ABC was developed out of Delaware on the coast. Here it works too. We found that it does continue to maintain its efficacy. We know that reported behaviors improve, attitudes and beliefs among caregivers across diverse Kansas populations are improved. We have built foundational partnerships with Kansas service providers through this work. I think we've established really good relationships, and hopefully we can continue to build on those moving forward. We've reached a ton of families through phase 1 and phase 2. Phase 1, I think it was about 460 families, and through this we have another 91 infants and 74 toddlers. We've enhanced our early childhood system by introducing the ABC early childhood components we've added to the literature on ABC early childhood. We know that there's increased feelings of empowerment. We know there's decreased feelings of stress, and overall children have less challenging behaviors after receiving ABC. A key thing with this phase, as Amy mentioned, was we were really interested in school readiness for our toddler population, and looking at those brief P results, we see that we do have increased school readiness, which can, is key for academic success for young kids. And then, like I just mentioned, there's over 500 Kansas families have benefited from this that we're really proud of and excited about them participating in the initiative. So in closing, we just wanted to say thank you, sincerely, thank you to all of the kids, the caregivers, the families, the parent coaches who we had to all sorts of measures and the cortisol testing in phase 1, the supervisors at these agencies, and then also to United Methodist Health Ministries Fund. This work could not have been done without you. Your support has been tremendous, and we have really enjoyed working with you all on this, critical need.
Well, thank you, Dr. Gruby and Dr. Mendenhall. This was a really exciting project for us, and again, to see the results and the outcomes in ways that we had hoped when we started this investment many years ago. But to be able to see the results is very exciting, to validate the work that so many of our partners have been doing, and the families that have benefited from these services. So thank you all very much for that. With that, I'm going to turn it over to our panelists. And Elizabeth, I'm going to turn it over to you first.
Okay, wow. Well, thank you so much I'm still digesting all of that great information. So thank you so much for sharing. So I'm Elizabeth Burak. I'm with the Center for Children and Families at Georgetown University. We're a policy research center with the mission to improve health coverage for kids and families. I oversee our early childhood and maternal health work, so I spend a lot of time thinking about interventions like ABC and how to make them available to more families. So I was asked, and by the way, thank you to the United Methodist Health Ministry Fund for having us. We're always big fans of all that y'all are doing in Kansas. So I was asked to talk a little bit about how states are funding programs or interventions like ABC. And I think one thing I'm really excited about that we can talk about here is there has been a little bit, I think, of a lag within the mental health system, really recognizing the importance of sort of what some folks call early childhood mental health, early relational health, sort of really boosting and working on that parent-child relationship, because we know it's the foundation of early brain development and school readiness. So I think we're starting to see many more states look closely at models like ABC to say, how do we make this available to as many families as we can, or to make the similar types of programs available to really work on that early relational or early mental health. And so, because we know they can have long-lasting implications. And I think what's interesting is, depending on who you talk to in a state, this might be a home visiting program, a prevention program, an early relational health or mental health program, right? Program parent support. And sometimes, because there's so many different ways of looking at it, it's hard to see where the funding goes into these. And so I'll talk a little bit about how states have approached it, but just know, like with many things, no one state is the same. So we know that, I'm going to kind of go from smallest to biggest, but a lot of states have been using federal sources, right? That's the big game in terms of getting matching funds or pulling federal funds down. So we know child welfare is a big funder of programs like ABC, Title IV-E or Title IV-B of the Child Abuse Prevention and Treatment Act. Human services programs like the Temporary Assistance to Needy Families or TANF block grants are also a source of funding for home visiting. In the mental health and substance abuse treatment space, we have, SAMHSA block grants. And in the public health space, of course, Title V, the maternal and child health block grants can also be supporters of ABC-like programs. Most of you probably know, but if you don't, the biggest sort of dedicated source of funding to home visiting programs nationwide at the federal level was created under the Affordable Care Act in 2010. It's called the Maternal and Infant Early Childhood Home Visiting Program. I think the acronym is affectionately called MCV. And I think Kansas got just under $6 million last year. It was reauthorized in 2022. Major increase in funding and some matching opportunities. And the MCV is very specific about what it funds. It says, for us to fund this program with these federal dollars, the directions to states are, you have to fund mostly what they consider to be, or what HHS, the federal HHS, has determined to be an evidence-based program. The beauty here is that ABC is already on that list, so you don't have to jump through any hoops. ABC is a model they have found to be solid, and the research that you all are presenting today is very much consistent with the other research that's been done on ABC and some of those findings. That's sort of the biggest dedicated funding source, and states just got a new infusion of money. But I think increasingly, and for actually in some states for a long time, but increasingly we're seeing more attention back on the role of the Medicaid program to potentially fund, if not visits, then at least some portion of these programs for eligible children or parents that are enrolled in Medicaid. And so we are seeing about half the states, and I'll put some links in the chat for more information on these, but about half the states allow Medicaid to fund ABC-like home visiting programs in some way. I think what's great about ABC too is it's a home visiting program on that list I mentioned for HHS, but it's also considered to be sort of family therapy or parent-child treatment. And that is something that about 38 states will support as well in terms of Medicaid. So there's a lot of different ways sort of to think about funding aspects of this. I wanted to highlight your neighbor, Nebraska, because they've done something really, I think, innovative with this very idea. Nebraska a few years ago created an excess profit fund. So for the state Medicaid program paying private plans to run the Medicaid program, if they get over a particular threshold that they're not putting into services, they have to pay some of that money back to the federal and state government. So the state portion they put into a profit fund that then at the state level in Nebraska, they reinvest as state dollars into other programs. And so what Nebraska has decided to do is to take those state dollars that were returned from excess profit and return them into matching funds to pull down additional MCV funds at the federal level. And it's a little complicated, but it's a way that they've sort of used different funding streams together to try to get sustain and maximize access to home visiting in their state. So there are a lot of creative ways I think states are doing this, but what's exciting is the opportunity to potentially spread and scale interventions like this for young kids so they can show up in kindergarten ready to learn. So thanks so much for having me, and I'll excited to hear the rest of the panel.
Travis.
Good afternoon. My name is Travis Rickford. I'm the Executive Director for Live Well Northwest Kansas. We are a public health and early childhood agency located in Colby. And so we offer programs and services to 12 counties in Northwest Kansas. And depending on some of our initiatives, we go even past that. I was introduced to ABC when I started on May 1st of 2018, and without any experience with any home visiting program, a lot of experience in public health and in different initiatives that address chronic diseases, but not to this level. I asked our home visitors before I left to come to this meeting how many families we've impacted through ABC totally since starting, and the number was around 270. So for Northwest Kansas, that's pretty significant. I was asked to talk more about sustainability and what ABC looks like for our agency and other agencies moving forward. And if I have anything to say about it, sustainability will be a permanent, ABC will be a permanent home visiting program offered at Live Well just because of the impact that we've seen through it. We've been able to integrate it into other grant initiatives and other systems. Currently, we're looking at expanding the service into the healthcare system. So working more directly with healthcare providers and being able to have an ABC home visitor work with patients that are having any maternal health care. And currently we have 3 home visitors that are certified, Emily Palmer, Sandra, who's on this call, and then we have Liz Mershon as well. And Sandra specifically will be working with healthcare providers with a regional hospital located in Colby. Another part of this is the wraparound support that ABC has been able to provide. We've been really fortunate in that Sandra and Liz, who are certified ABC home visitors, are also community health workers. So they're able to provide that intervention, but also they're able to connect that family with other resources that may be available to them. So that's been really interesting to see an ABC family be referred for behavioral mental health care services. Last week, we helped an ABC mom get a mattress so she could have a bed to sleep in. Did not have access to those basic services. And through Sandra's ABC home visit, we determined that was a need and were able to get her bed sheets and supplies for that until she could get a more permanent residence. And I think it also highlights the changing demographic that we're seeing in Northwest Kansas, where we have over the last 3 years, we've seen increases in our demographics, especially as it relates to Hispanic families. We have more Hispanic families moving to the region, and ABC, and especially with Sandra and Liz's experience as ABC home visitors, has really been a concrete support that we've been able to offer those families and see some significant gains there, and being able to work with every family in Northwest Kansas, not just the ones that we're used to working with. And so overall, I think as we look forward here from today, it's a lot of right now it's hard work for a small nonprofit agency to sustain these programs and without the strategic partnerships and funding that we have. So as we look into the next 2 years, I'm not sure if that will be more difficult or not, but that remains to be seen. But one thing I know for sure is that we'll work to make ABC a permanent program for families in Northwest Kansas. So thanks to the United Methodist Health Ministry Fund and thanks to KU as well for all of the work that you've helped us with over the last, and for the ABC folks here on the phone too. I saw Kim and earlier, so thank you.
I am Audra Kennison, and I work at Rainbows United. Rainbows is located in Sedgwick County, Kansas, and we work with children with developmental disabilities and their parents and their caregivers in Sedgwick, Butler, and Sumner counties. And at Rainbows, I have the pleasure of being the mental health coordinator and also the specialized foster care coordinator. And through this project, I wore my mental health hat, and that is one of the things that they've asked me to talk about today. And I want to echo Travis and the others in just saying thank you. The United Methodist Health Ministries group was just incredible partners, and they supported not only the individual grantees in their work, but just everyone in general. And what we learned was that they just built a sense of community for us where we were able to come together, and we had this invaluable resource of time when we were together, and we had open communication and built wonderful partnerships. And I know even today, if I pick up the phone and call Travis or Katrina or Anne Marie, they are there to have the conversation or to give help or to spread the word about something we want to talk about. So thank you to them. And also working with the KU team was an absolute pleasure. We appreciate their positivity and their strong communication, and we truly value that they took our data to tell a story about the work, and that was really special for us, so thank you. At Rainbows, our mental health team historically serves children birth to age 5, and we were part of the infant program with this. And during this grant, we focused that work on infants in Sedgwick, Butler, and Sumner counties. And since the grant ended, we have continued utilizing ABC as one of the evidence-based tools in our therapist toolbox. And we've seen good work from that. Rainbows is the Part C provider for the counties that we serve. And so through that partnership, we received most of our referrals came from Part C providers. And even though we work close with them and they did those referrals, we are not part of the IFSP process, and we were a separate project from what they do. And I think it's important that we talk about that. When we work in early childhood mental health, our focus is always on prevention with families, and many of the infants that we serve have some levels of trauma, which means the family has levels of trauma. And so we work a lot on attachment and that social emotional well-being of those infants and toddlers and their caregivers, which is what ABC really highlighted. I think what we want to be sure we talk about is that when we're speaking of infants and toddlers who are part of the children who have medical trauma, who have had really rough starts, that we acknowledge that that is part of the trauma that families deal with. We tend to think of trauma as abuse, neglect, and other social issues, and absolutely those are traumatic. But an infant who starts the first few months of their life in a NICU and has medical intervention constantly and very little touch and connection also experiences trauma. And so that was a lot of what we learned we were focusing on as well. When we were approved for this grant, we knew that we wanted to work on sustainability. That was a big part of the goal. And for us, that meant we were going to begin Medicaid billing in whatever way we could. And to that end, we made sure that we identified staff who were clinicians, clinical therapists, who were able to do the process that is required. In order for us to do that Medicaid billing for therapy. As Elizabeth talked about, we could talk about ABC as a home visitation. It's an excellent home visitation program, but it is also therapy. And so we really dove into that. Our clinical therapists were already educated in how to diagnose, but we weren't really, we didn't know enough at that time about diagnosing infants. And so that became our project. And everybody who sat at our table knew that that was what we were going to do. And they heard about it all the time. But that was part of our longevity. And through that, it took a couple years of investigating the actual how to do it. It took a while to figure out our process and procedure, but my staff were excellent. Cindy and Leslie both were excellent in helping us figure that out. And so we've been successfully doing that since 2019. Though it doesn't bill a great amount of money, it is a way to have extra income. And so through that, in the spirit of United Methodist Health Ministries spreading the love, we developed a diagnostic training that now we are able to offer in Kansas to our therapeutic partners and teach them how to use the DCO5 and do some really good education. And in 2024, we educated 89 therapists in Kansas to teach them how to work with infants and toddlers. And I'm over my time, so I'm going to stop. Thank you.
Well, thank you, Audra, Travis, and Elizabeth for your good remarks. David Jordan with the United Methodist Health Ministry Fund. And thanks to Whitney and the entire team at KU for all of their work. As we reflect on this project, we got into this work because we recognize that children's earliest years in life have a lifelong impact. So we know that 90% of brain development occurs by the age of 3, and that having a healthy start affects health, educational attainment, and earnings throughout life. And really, it's exciting to see this research to show those impacts, especially in the educational readiness, which we know will help lead to educational attainment. We also know that many children are dealing with toxic stress and ACEs, which have an impact on overall development. And we know that ACEs are common in Kansas. 39% of children have experienced an ACE and 20% have experienced 2 or more ACEs, which is exciting to see, which is why we invested in this work. And it's exciting to see the outcomes that ABC can offer to counteract the impact of ACEs and toxic stress. And as we think about the future, we think about different ways ABC can make an impact and different ways to finance it. So we've already heard about some ideas through the child welfare system, through Part C, through Medicaid. And I think these results will help us make that case. And we look forward to continuing to partner with the teams at Live Well and Rainbows and with the KU School of Social Work. I think lots of great work has happened on this project, and we're excited to see what's next. And I know that this was a long project for Dr. Mendenhall and Dr. Gruby and everyone involved. So lots of exciting outcomes. So thank everyone for being part of it, but also excited to think about how we can continue to not just elevate this intervention as a way to improve child development, but just help lift up the importance of making investments in this space and working innovatively with Medicaid offices to cover interventions and home visiting, because it really is the smartest investment we can make as we think about funding choices. So I'll turn things back over to Katie.
Well, thank you. And again, it feels like a labor of love to be at this part of the project and seeing all of the very positive results. As David mentioned, when we were first looking at this, we were hearing about children being expelled from preschool and challenges from that age, and thinking about how many more of these children are ready to go to preschool or ready to go to kindergarten. And we know that in part because of the home visitors and the staff at all of the agencies that we worked with, again, as David mentioned, Rainbows, Russell Child Development Center, Project Eagle. We also worked with Horizons Mental Health Center and then Live Well Kansas over the last 7 years to really see the implications for these families. We know that they're thriving, more of them are than were coming into the intervention, and that they're seeing positive outcomes. And so I'm very pleased, and again, feel very proud of the work that all of you have done to help support the families and children in Kansas to have a better outcome for them. And so with that, if we have any questions from the group, we will open it up for a few minutes for any questions that we may have. I don't see any in the chat. If anyone has any.
Hey, this is Lisa Williams with the
Okay,
State
then.
Department.
Well,
Oh,
that's the case. Then
sorry.
we were finished a few minutes early. Thank you all again for joining.
Katie,
Oh, yes.
Katie, Lisa was speaking, but it was pretty quiet. I'm not sure you heard her.
Oh, no, I didn't. I can't.
My computer takes a while to kick in when I'm talking. I don't know why, but I'm with the State Department of Education, and my role is with the Parents as Teachers evidence-based home visiting project. And so I was very interested to hear about the ABC work taking place in Kansas. Do we have any idea of like a cost per family for this intervention? It's okay if we don't. I think that's fairly new to the evidence-based home visiting world, but I was just trying to get a general sense of what the needs are.
I would say the tricky part is it looked a little bit different. And again, it would vary, I think, from even probably phase 1 to phase 2, in part because of some families. I think there was a lot of discussion even about how long it took families to get through the intervention, and then also how many were completing. So you heard Whitney mention that only 60% of the families finished phase 1 versus phase 2, 80% of the families finished. So I think even in looking at the variation, we also were figuring families. So again, when you look at Russell Child Development Center and Live Well Northwest Kansas, some of their home visitors were traveling up to 2 and 3 hours to go see a family versus those that were more from the metropolitan area that weren't having to travel quite as far. So caseload wise, that's a little bit harder too. So I don't know that we have actual figures that we could say like, this is exactly what it would cost, just again, because of the variation and the demographic, like the locations and geography where they're serving, and then also the families that they're serving. So I'm sorry, I can't give you a more specific answer on that, but that's a great question.
That's okay. We wrestle with the same thing, and PAT has been around for 40 years, and so I understand
For
all
sure.
the variations. Do you see this as an intervention that can work with other home visiting programs across the state in terms of referral once the family has completed one project or one process?
Yeah.
What would that look like?
I may even I was trying to see if Travis or Audra,
Yeah.
as they both have multiple home
Yeah.
visiting. Okay.
Yeah, we partnered. One of the things that was asked of us is to ensure that they had somewhere else to be involved with after they left or before they came to us. And so we work closely with parents as teachers. We work closely with our Part C providers so that after they were done with our short term, they typically had somebody else that was seeing them. And if they were involved in parents as teachers, sometimes they continued while we worked, and sometimes parents as teachers paused it and let us do what we did, and then they would pick back up.
That makes
That was
good
the same
sense.
for our home visitors as well. We would often refer the family to either another home visiting program, which included parents as teachers. So that was our idea of providing that continued wraparound support for the family.
I think one other important factor that we heard a number of times, and Dr. Gruby, Dr. Mendenhall, feel free to interject too, because there was a lot of qualitative data that was gathered during the first phase of the project, but that we were hearing multiple times too, that families felt more comfortable for a referral after they went through ABC because of the positive parent coaching model that really is attributed to. It gave them a more positive willingness to engage in different types of home visiting programs after they completed it. And so a lot of them saw it as almost like an entry into other types of home visiting models, and then also more willingness for the other wraparound services. But ABC is very specific and targeted. We talk about that. It's not a cure-all for everything else. They really need those wraparound supports. It does help build attachment. It does help with family empowerment. But again, it doesn't provide all the other supports that the families need.
And with parents as teachers, there's really a good opportunity for the two programs to work together. Not every family that may take advantage of parents as teachers needs to participate in ABC. So that's really why the screening is so important. It's more of an intensive program.
Great questions. Are there any other ones from the group?
I just wanted to say that I'm Kimmy, I'm the Director of Site Implementation for ABC. And these questions have been really great and questions that we're hearing from other states as well. And so if there's any additional support or information that we can provide from ABC as well of how other states have been implementing and how they're incorporating ABC in their programs, we're happy to help in that way. And I can put my email here in the chat for everyone if a connection is helpful.
And one final plug on that as we're thinking about it too, is that their United Methodist Health Ministry Fund, we still are helping support training for ABC coaches. And so if there are other types of home visitors that are working within your programs that would be interested, we have an application process that we are willing to open up for providers so that they can expand to Audra's point, their toolbox and be able to utilize other types of home visiting models that might make sense for them. So feel free to reach out to me if you have any questions on that as well, or other staff at United Methodist Health Ministry Fund. Okay, with that then, I just want to again say thank you to all of you for joining us for today's session. And again, we really appreciate the work that Dr. Mendenhall and Dr. Gruby have done to put together the evaluation, really, again, to tell the story for what we're seeing and experiencing with these families. Again, to each of the sites that participated, thank you so much. This would have not been a success without each of you and all of your continued engagement over the years. So thank you all, and thank you for joining us today. Again, it will be recorded and sent out to everyone. Feel free to share as you'd like. Have a great rest of your day.